To start off, our moderator for today is Dr. Nikitra Burse. She is the owner and CEO of Six Dimensions, a certified women-owned, minority-owned public health research and development company. With over 15 years in public health, she holds her bachelor's in biological sciences, her master's in health education and health promotion, and a doctorate in public health. Her work focuses on health equity, social justice, and improving maternal health outcomes. And she is the executive producer of Laboring with Hope, the documentary that we just watched together. This has been featured on platforms like BET's Disrupt and Dismantle series, The Kelly Clarkson Show, the CDC, and various other national media outlets. And she has 2 children. Our first panelist today that I'll introduce is Dr. Alex Jones-Adeshina. She is a family physician here at Waco Family Medicine in Waco, Texas, and she also serves as our Chief Equity Officer. She graduated with honors from Northwestern University Feinberg Medical School in 2016, and she also holds her MPH, her Master in Public Health, making her an even more well-rounded physician. Dr. Jones-Adeshina has years of diverse experience, especially in family medicine, and she has 3 children. Our next panelist I'm going to introduce is Lauren Montgomery. She is the Nurse Perinatal Coordinator at Ascension Providence, and with 24 years of experience, she specializes in perinatal care quality and outcomes. She leads Texas AIM initiatives, perinatal loss support, and obstetric stimulations, also managing maternal and neonatal services. She has certifications in inpatient obstetrics and maternal newborn nursing, and she's earned awards like Daisy Nurse Leader and Healthcare Hero for Equity Work. As Ascension Providence's 2023 Nurse of the Year, her passion lies in improving Black maternal health by addressing maternal mortality disparities and educating healthcare providers. Off duty, she cherishes time with her husband, Kenneth, and her 2 sons, Caden and Kai. Our last panelist that I'm going to be introducing is Lucretia Duffy. She serves as the Executive Assistant for Community Doulas of Waco. Her journey into the world of doula work began in 2018 when she experienced the profound impact of having a postpartum doula herself for the birth of her 3rd child. She wasted no time. With her 6-week-old in tow, she embarked on the journey to become a doula herself. And since then, she has had the privilege of both receiving and giving birth and postpartum doula services, both in private practice and within her community. And she's a mother of 5 with number 6 on the way, coming in spring 2024. So I'm going to turn it over to you, Dr. Burse, and Q&A can be submitted all throughout. And again, as CHWs, if you have any questions, please send those to Chantel Miner in the chat.
Okay, well, thank you, Megan, for having us, Waco AHEC, and thank you all for joining this afternoon. I'm really excited to hear from everyone, and I'm encouraged by the discussion. I saw a comment in the chat that someone said that they were saddened by this, but hopeful, and I think that's where we all should land right now. It is a very critical and dire issue, but I'm hopeful, though our numbers don't seem to be declining at the moment. The good thing is that there's a big highlight on the issue of maternal morbidity and severe maternal morbidity and mortality. And also there's funding that is going toward the issue, and there are community-based projects that are working on the issue. So I'm encouraged by what we will see in the coming years through all of these collective efforts. And so we will jump right into the discussion. We heard some about the data, and though that data reflects around 2019 to maybe 2021, we're still seeing some of the same issues. So where we can kind of start this discussion is around those factors that contribute to the inequities and disparities that we see. We know that socioeconomic factors play a role. That means if we can or cannot afford healthcare, afford just to live, our wages, access to quality care, and that historical context of racism. And so even our predisposition to other health conditions. And so I think it is fitting for all of you to maybe just give your thoughts around this issue of, we call it implicit bias, but we also know that it is important that we name racism and systemic racism in this. And so maybe if you all could just kind of talk about how implicit bias, racism impact the healthcare system from where you sit, whether that's as a provider or a patient. And anyone can feel free to go.
Dr. Burse, I think you had an amazing introduction to it, just talking about the legacy of our women and how historically our women have been treated in the past, just with treatment or lack of treatment, and not knowing the procedures that were being performed on them. I think that that even though that's happened in the past, it definitely is very, it speaks to the lack of trust of providers that we see in women today. So we know that when we hear about there was delays in prenatal care or late prenatal care, and then we really do a deeper dive, we understand that it's because of the lack of trust of some providers, or just the fear of what's going to be done to our bodies because of what has happened historically. So I'm glad that you mentioned that in the film.
I would like to add that I think sometimes the way that the issues that our patients come with can be shed in a light that is negative and that is blaming of the patient, right? So when we talk about a patient being late to prenatal care, sometimes it can be documented in the chart as though that is the fault and the onus of the patient, as opposed to recognizing some of the societal barriers that our patients face, right? So if you can't get there because you don't have a ride, well, we can blame you, or we can say, let's find transportation. Let's be, very clear about what your, where you have strengths and where we have barriers that we need to address. So.
And also there's this generational, and I love what you said, Lauren, like a fear, a stigma around going to the doctor, even though we know that there is, things like the emergency room, or for example, here in Waco Family Medicine, it's this stigma around knowing something terrible is going to happen. There's never this positive thought of going to the doctor. So whether it's pregnancy related or just general health concerns, you can see that being passed from generation to generation. And I think that is still very much prevalent today in 2023. So yeah, it's still happening.
Yeah, and Lucretia, you mentioned it being passed from generation to generation. And when it's passed, we don't often know why it's passed down. Of course, because we lose some things, in that generational passing down of information. But we do things because that's how we've done them before. And but we haven't had an opportunity to really shed light on the historical context. And so I'm always excited to hear us bring in that historical context when necessary. And Dr. Jones Adeshina, I also, when you talked about like transportation and those barriers, that's critical. If we don't take everything into account, because people don't just come in with that one singular issue. They come in with their whole life with them. And many of us live in rural communities. And so it may be a 1 hour to 2 hour drive just for someone to get to that type of care, because OBGYNs may not be in their community. And so thank you all for bringing in those points. Lucretia, I wanted to kind of move back to you as a doula. Over the past several years, my children are 9 and 5. And for my 9-year-old, I had no knowledge of a doula. And with my 5-year-old, I was just having a conversation with someone this morning, and I was like, I actually thought doulas were for wealthy white women. That was, I did not know much about the profession then. And so can you talk about doulas as a strategy to reduce some of the issues that we see, specifically around bias, maybe?
Okay, yeah, that's really good. So, doulas historically have been for middle class, upper class families. So, absolutely. But also, if you look at our generation, our family as Black women, we've had doulas. They just weren't called doulas, you know. We've had aunts that come over to help us, people from church. Our mothers stepped in, hopefully, or our grandma, or in my case, Big Mama came in to help out, you know. So they just didn't have that name of doula. And so it is still quite a foreign new word, but the history itself is speaks. And so recently, within the past, I would say, oh my goodness, maybe 8 years, the term is slowly becoming more available to everyone. And when I say everyone, that's more community based. And so the doula is a support person that supports the mama, you know, prenatally and after the baby's born in the postpartum stage. And so they are non-medical professionals. And then they focus on, you know, that information support, educational, and of course, my favorite, the physical, the hands-on support. And so if you think about that, you're like, okay, maybe I have had someone that was like a doula to me. But I must emphasize that doulas now in 2023, they're either trained or certified. So now if you carry the name doula, that usually that training or those credentials will come with it.
Thank you for that. And so if you all don't mind, I'm an informal person, so your discussion kind of brought in some other things. So I kind of want to skip a little bit to our community and healthcare perspectives. And this also was spurred by a chat that I saw in the comments. Someone said, mentioned midwives was called before. So there is a difference between a midwife and a doula. A midwife can actually deliver babies while a doula does not. So as you mentioned, a doula is not a medical professional. But what is the importance of patient and provider communication? And I would actually like to hear from all of you from that perspective, because doula kind of bridges that gap sometimes with the patient and provider, especially when there are issues of trust. And anyone can go. Yeah.
Yeah, so this is my passion, because when it comes to relationships, is so important with a birth and postpartum doula. And so building rapport with the provider is one of the first steps as a doula. Their job is to be able to know everyone in their community. And then also on behalf of the mother and the family, really empowering the mom to advocate for herself. Now, she does not step in on behalf of the mother, but she empowers her by giving her the information that she may need, or physically just being there with the mom while she goes to OB appointments, or just trying to process the information her OB is giving her. So really focusing on the empowering aspect and building relationship is one of the many roles of a doula.
Thank you. And Lauren, would you like to go next?
Sure. So I think Lucretia hit the nail on the head with just establishing a rapport, because that is what's going to build trust. And hopefully that will come well before it's time to deliver. Like you've done that during your prenatal visits, and not just with your primary care physician or your OB, but if you're seeing any specialist, I think it's important to, I think it's almost like you need to have a care plan meeting with everybody, the whole multidisciplinary team. So your OB, if you're seeing any specialist, even if you feel like you're going to need NICU involvement, maybe the neonatologist. I don't know if every site offers that, but I think it's important to get all of those people on the same page so that the mom's desires and their wishes can be discussed and then honored when it's time to deliver. I think establishing that throughout the pregnancy is key, and then bringing in those support people as well.
I can end by, or at least this topic, by sort of talking through the different approaches that providers take. And so I think sometimes, I only knew this because I trained in the medical profession, but the perspectives and the approach to taking care of a patient who is pregnant varies depending on who you are working with. So if you are working with a family physician, it's going to be a different approach than if you're working with an OBGYN or a midwife. And yes, all of those are hopefully going to end in a nice, healthy delivery, but the approach to how you get to that point is going to be different. And so it's up to each patient to approach their pregnancy with that in mind, knowing that depending on what your delivery and care goals are, you might choose who that might affect who you choose to be a part of your journey. And the nice thing is that doulas can be, and community health workers especially, can be really helpful to connecting moms to all of the resources in their communities, because doulas is one of them. And I'm so grateful that our community has them, but there are lots of different resources that can fill all the needs that our patients have, especially and increasingly more in the postpartum period, where a lot of the risk can still happen. So coming in with that understanding that not all providers offer the same perspective and approach is really empowering and important to know.
Thank you for bringing that in. And so when we think about the families that we work with, it's important to first think about what type of care you want, and then kind of seek out providers, a team that can really fill that role. That's what I'm hearing here. And we are all saying that with the knowledge that many of those that we may serve in our communities don't have that type of access to make those very good choices. And so then we do our best to try to equip them with as much information as possible so that they can make those good health decisions. And Dr. Jones-Adeshina, you brought in a point about this collective team and how everyone kind of works together in different ways and different practices. And so that makes me think a little bit about what are some innovative approaches to care in your communities. What things are you seeing? We've seen some, of course, increases in people using doulas and midwives and other types of care. But what I'm also encouraged about is seeing quite a bit of lactation support, supporting families in breastfeeding and initiating and continue to breastfeed. I was like, everyone says 12 months, but I'm seeing families that are going much further than 12 months. And then the linkage to mental health, or the acknowledgement that there is a need for mental health, has been very critical in the things that I've seen. And so I would just like to hear from you all on some things that you're seeing in your communities, or what you're doing in your community that has been innovative and shown to work.
Yeah, thank you for that question. At Waco Family Medicine, which is where I practice, we have a woman whose sole job is to help to connect our patients with the services that are going to help them have a healthy pregnancy beyond just the delivery. And so a few years back, she helped shepherd in what's called centering, which is group prenatal care. It's been shown to be super effective at lowering comorbidities from pregnancy. And it actually, within the last maybe 5 years, it has extended to centering parenting. So that same group of moms who are put into a group based on when their delivery dates are expected to be, can then continue in those first 2 years of care for their kid to create community, to swap stories, to, when things are really rough and they're going through a rough patch, to have that community. So that's one of the programs that we're really proud of. We also have lactation, like you said. And, the nice thing is our lactation consultant will get with patients pretty much as quickly as we've identified a need and an interest. And so some of that happens before the delivery. One of our community partners is also the Nurse Family Partnership. And so we refer to them for, they sort of bridge the clinical gap in terms of helping us understand what's going on when patients are at home. They come and get to know our patients very well. They will check blood pressure if that's necessary. They'll help with diabetes management if that's necessary. And those services also go beyond delivery. And one of the ways that we continue to approach that is to continue to look at our data and to think through what is the data telling us about what we're hearing? What does the medical literature tell us? And then what are our own results to know, should we be changing how we're taking care of our patients? So, but I'm sure others have other really exciting things that they're doing to address this issue.
I definitely would not be doing my due diligence if I didn't just talk about Community Doulas of Waco. We are the only nonprofit organization offering birth and postpartum doula support in all of McLennan County. And I say Central Texas, so it just depends on how far Central Texas we're going. But we are offering this doula support to mamas. And it's a beautiful thing. And we are very strategic about who we are focusing on offering doula support to. So in order to register, the mother has to be between 30 and 34 weeks pregnant. We cannot register them anytime before then because life happens. It's easy to forget. But we've noticed when we target them between that 34-week mark, they're all about business and they know what they want at this time. And so they have to be receiving any type of government assistance. So that is Medicaid, WIC, SNAP, Section 8, just something. And then also residing within a 10-mile radius from our office. And so we have to narrow that down because we do have a small team of birth and postpartum doulas. So as of now, it would be great if we could travel out and just serve everyone. We just don't have the capacity. But we have been able to make a dramatic change. Community Doulas was started in 2019, so literally right before the pandemic hit. And I think during that time, we only had maybe 3 or 4 clients. And now in 2023, we've served so many families. As of now, we already have served like close to 80 clients. And so we're doing our due diligence and it's just taking time, but offering that free support to the mothers has changed a lot. And so I'm really, really proud of that.
Lauren, did you have anything?
Yeah. So with me being in the hospital, sometimes I always feel like it's a barrier just with timing because so much of this work needs to start before they get to the hospital. And if you have an uncomplicated vaginal delivery, you're only here with us for 24 hours. So it's a very narrow window to, I feel like, to address all the needs that need to be dealt with. And you're kind of competing with time with lactation and birth certificate and hearing screen, all these people coming in and out of the patient's room. But I feel like partnering in the community. So we have a regional advisory council where there's a site representative from our hospital, the other hospitals. We try to partner with Waco Family Medicine and Community Doulas of Waco so that we can get that information out ahead of time, just the services that we offer here. And I think standardized approach to how when a patient does arrive to the hospital, that kind of looks the same throughout our region. So standardized order sets or participating in Texas AIM, which are safety bundles, so that whether you're at our site or another site within our community, you can, that gives the patient some reassurance that they're going to receive quality care. So those are some things that we're trying to implement and get awareness out to before a patient arrives to the hospital.
And I just want to add one other thing that's really important about, at least within the state of Texas, is sort of the structural components of things that our patients have. And I think this sort of got lost in the news because, the news anyway. But Texas Medicaid actually covers moms for up to a year after they deliver, which previously only covered them up to the 6 weeks after, which in my personal opinion is like right when scary things are starting to happen, and then they lose their insurance. And so it's so important that we know that because a lot of moms do not know that. And so it's our ability, that extends our ability to take care of them if they, have insurance throughout that whole period of time.
I think that's also amazing because we now know that the postpartum period is not just the first 6 to 8 weeks. It's literally like the first year after having a baby. And to know that Medicaid is doing that, covering that mama for a year, that's amazing. And even so, like switching programs, if this mother qualified for Medicaid, they automatically switch them over to, I believe it's called the Healthy Texas Women's, which continues postpartum support as well. So, and monitor them for risk for like high blood pressure, postpartum depression. So there are some things that are happening. So that's awesome.
Well, you all moved us into the next part of our discussion, which is around policy and advocacy, and how that impacts this work that we're doing. You both mentioned postpartum extension, Medicaid extension. And I live in Mississippi, and Mississippi has not expanded Medicaid, but in this legislative session, we did extend postpartum care as well to that 365 days. And it is my understanding that Texas has not fully expanded Medicaid as well. And so we know that continues to present barriers to receiving care. But I would like to talk a little bit about some additional policies that you may have seen that are impacting. We know there are some on the federal level. The Momnibus has been kind of lingering around for a little bit. The Pregnant Workers Fairness Act, as well as the Pump Act. And we can go back through those, but I did want to give you all an opportunity to respond to anything around policy or any additions to policy that you may have before we kind of dig a little bit deeper into what those mean. And so whomever feels comfortable responding.
Yeah, so policies is very delicate subject because as a mother of almost 6, you could just want to scream from the rooftops what you want to, have done. And it just takes time, and it doesn't happen as quickly as we like. But there was a bill that was passed. And this bill recently, I can't remember the exact bill, but it covers, at least for now, we're trying to work out all the details for doulas and community health workers to be able to provide case management support to pregnant women. So there will be some type of Medicaid reimbursement for that. They're still working out the kinks. And so we won't really fully know all the details to it until it's all worked out. But there is some policy in Texas that's trying to take root. And as far as the physical support and being reimbursed for that for doulas, that still hasn't happened. And we know that in order to give the proper support to mamas, like, it takes funding. And so hopefully this will open up the door for more bills and things like that, policies to be passed in the future.
Any others?
So again, because I'm in the hospital, I can speak to policies that have taken place once you're inpatient. And we're very grateful that now Joint Commission and like maternal and neonatal designation levels of care that are, state requirements have really honed in on this to encourage us to stratify our data by race and to also include the emergency department. So that kind of speaks to this follow-up, because a lot of our policies and order sets were just for our like labor and delivery, postpartum, just like women and newborns. But we see a lot of these patients present to the emergency department, both during the pregnancy and postpartum. So I think making sure that our staff that works in the emergency department understands these statistics and how these patients need to be monitored differently, specifically like with hypertension. What we see in pregnant patients are more alarming than what may be in the emergency room. They see severe range blood pressure, and they be like, oh, we see that all the time. We're like, no, this woman just had a baby. She could, have a stroke. So I think just getting that information out and making sure that all disciplines understand what's going on with maternal morbidity and mortality is very important.
I agree. I think, each of us has a unique position in this sphere. And so it feels like what's in the locus of my current control is to work on the organizational policies that we have to be really connected to the way that the data, determines how we take care of our patients, and to be brave enough to like think outside the box and, make do with the resources we have given the political, environment that we're in. And so sometimes it's depressing because it, like Lucretia said, it seems so straightforward, and any woman who's had even a single pregnancy can totally relate to the things that we've been hoping for. But in an era where that's not straightforward to achieve, we focus on what we have.
Yeah, and thank you all for even the real optimism in this because I'm always like, the policy needs to change. So thank you for your optimism in this. Lucretia, I wanted to kind of double back to what you talked about around doulas and community health workers being able to bill as social worker case management, so to speak. And I think that's important because in some states there has been a discussion of like that dual certification or training for community health workers to serve in the role as doula. So we have more policy to consider in the future there. We also have more policy to consider around the reimbursement rate. And I think we could all probably think about that from every provider standpoint. And then Dr. Jones, Adeshina, you did mention about organizational policies. And I think those, even when we can focus on those things that we can change, that is very critical. My sister that you saw in the film, she always tells a story about when her baby was in the NICU and she was staying here at my house. Her home was 2.5 hours away from where we live. And so they called and about 3 a.m, she ran to check on baby. And when she was leaving, she didn't realize she didn't bring her purse. And so she didn't have the $3 that she needed to get out of the parking garage. And it was not that, the parking attendant was just being so mean. They were following a policy that was set forth. And so after she got out of the NICU and, kind of began her piece of how to advocate, that was an organizational policy that could easily be changed. NICU families may not have to pay to be in a parking garage. And so as we think about the big barriers that present, it's very hard to kind of follow up with these big picture policies, the big P policies that we call them at the federal and state level. But there are things that we can do in our local organizations that can really make practices more equitable and, community facing. And so thinking about that, thinking a little bit about the amplifying Black voices and how we engage Black women and Black families in this care. And so a lot of this really is about how we are, I hate to say empowered, but how we are really able to make good health related decisions because we are confident in our knowledge and education. And so can you all just talk a little bit about the role of community engagement in improving maternal health outcomes? And I really like, you all have like 3 different perspectives on everything. So that's why I'm asking you all to each just give your perspective, because I think it gives us a good view, a good comprehensive view of this issue.
I like to engage my patients' communities early. So when they come, I always try to understand who are the people that are important to them, whether it's a partner, a sister, a mom, a really good friend, all of those people. And I often invite them to come literally to every visit. And I have to say that sometimes it's the partners in the room, the family in the room, that provide the details about what's happening. And they sometimes are picking up on things even before my patient is really acknowledging that it could be something. And so I think having that third person in the room who can also be a second set of ears, who, there's so much that can be leveraged, and they help, I think, elevate the voices of our patients. And there's learning on their part. Like a lot of times, dads in particular really want to be participating, but because they don't have an experience of pregnancy, they don't always know what that looks like or how to do that. And so those visits really help us to build that, to help educate throughout the whole process about what does it look like to be well, when should we be hearing about it, and what can we do to support throughout. And I think it's often about recognizing where my skill sets are and where my skill sets aren't. So I'm not, I can teach a little bit about lactation. I'm not a lactation consultant. And so when I can help in the moment, but I know that I need to connect that patient with other people who have those skill sets. And so it's just about thinking through, like, I've noticed this problem a lot. I'm seeing a lot of thrush in my newborn moms, in my new babies. Is it because they don't have an easy way to steam and sterilize, pump parts or baby bottles, and just being aware of what things are happening enough, and finding a community partner who can really partner and meet that need.
That's really good. I know that for Community Doulas of Waco, we don't just stand by and wait for a phone call for mamas to be interested in doula services. We're actually on the ground and going to pregnancy centers, going to centering classes, going to outreaches, going to churches and any events they may be having. And we're setting up booths wherever we can get in, even if it's at, a school or wherever it may be. We're trying to make sure the community knows about this free service that's available to them. And so from there, and I must point out, there may be times that even at the grocery store, we've had that happen a couple times. You are always a doula, like 24/7. And so even there, we still, I mentioned it earlier about building rapport with the clients. And so just like what you guys are doing, Dr. Destina, whenever we are registering clients, we are building rapport with them, especially from the perspective of first, a birth doula, because you have to be comfortable with that doula. When it's time to have that baby, you got to know that your doula is going to be there for you. There's going to be some things that's happening in that room, and you got to know that you can trust your doula. And so they are very intentional from the time that they meet and greet to childbirth education, to breastfeeding education, comfort measures. They're very clear. This is going to be hands-on, and then integrating the entire family. Our postpartum doulas are doing the same thing. They're building that rapport with the mama because they know how fragile the postpartum, period can be. And so they're welcoming everyone, integrating everyone to this little human that's now here. Even the dog needs to adjust, the animals. So, tearing down those stigmas of a big one is breastfeeding, and so being that support person and supporting the parents' decision of what they want parenting to look like. And so they're on the ground, they're in the homes, they're at the grocery stores. These doulas, they're everywhere.
And I'm very fortunate to work for an organization that does allow me to go out into the community. So anytime there's like health fairs, we have a table set up there, and we're able to go ahead and start talking about like post-birth warning signs or things that will that the patient and the family should be looking out for. Also, we know that our patients heavily rely on social media. They get a lot of their information from social media. So there is someone amongst our group of physicians, and that is her job, to go onto social media, into some of those moms groups, and kind of dispel the myths and make sure that we're putting out factual information and kind of informing the patients of what they can expect when they get to the hospital, but also just warning signs, so that they are, I think listening to other moms are great, but sometimes that information just isn't the best. So just making sure we're giving evidence-based information in those groups.
Yeah, that's important. And thank you for bringing that in too. I think that's one thing that we have to continue to push as we work in the community is, yes, that peer-to-peer support is critical, but also let's make sure that we continue to look and find things for ourselves and, reach out to our other trusted sources so that we can have a good picture view of how to make those make those decisions. And so just a little conversation around kind of intersectionality, particularly in this crisis. We're talking about race, gender, and all these other factors that play a role in maternal health outcomes. And I'm also thinking about even social class as a piece of that. We briefly mentioned socioeconomic status, but how important is it to you all in the way that you maybe structure your services or practice in recognizing all those things? And maybe I should have probably asked this question a little bit earlier in the discussion, but really, how do you take into account everything that a person brings with them and every identity that they may take on in the context of pregnancy, postpartum, and their reproductive health as a whole?
Yeah, I think that once again, I'm speaking from a perspective of a doula and then also as a mother, is meeting them where they are, and not just assuming that these families or the moms in particular have it all together, and just realizing that they're humans and we're all just trying to figure this thing out. But alongside with that, it is so important to offer that evidence-based information. So we're breaking down a lot of walls, like I mentioned earlier, just by being a doula and showing what the evidence says, not my experience, not what your grandmother's experience was or your great grandmother's experience was, or even the previous pregnancy. None of those things are going to be the same. And so having that evidence based information available, but not judging them, and just being that support for them wherever they are, meeting them where they are, is so important as doulas. And I believe that's what makes a person a successful doula, is if you are able to meet them where they are and get them to where they're trying to go, and just meet them in between there. So yeah, that's what I think.
I think that when we talk about meeting the patients where they are, so we do have in our admission assessments, social determinants of health. And so that's done on every patient when they present to the hospital, and will may trigger a social work consult, kind of depending on how they score on that. But it is asking individualized questions that kind of tell us who this patient is, what they're presenting to the hospital with, outside of just what's happening with that pregnancy, but all of the social determinants. And then when we talk about stratifying by race, it's so important that that's self-reported. I think some barriers that when we first started tracking this data, which I feel like that's how you have to get in front of hospital leadership. You have to have the numbers. Like me just standing up saying this is what's happening in our country isn't enough. They want the data to back it. So when we start stratifying by race, I think initially it was kind of whoever the intake person is, maybe like in admitting, or if that's nursing staff, they were just kind of assuming what the race was and entering that. But we had to change that and make sure that the patient is self-reporting it, and that we were seeing a lot of unknown and declines. And I'm like, are these patients really declining their race? And when we looked further into that, some of them were declining it because they felt like they would be treated differently based on what they said their race was. So my response to that is yes, you will be treated differently, and you want to be treated differently. And that's when that whole discussion between equity and equality kind of comes into place, because we know that some Black moms respond differently to different antihypertensive, and we know that Black baby girls have different outcomes in the NICU. So that is, I think just doing that education to where they feel like it works in their behalf to kind of disclose what their race is and not to harm them, is the education that needs to get out.
Evidence-based medicine, I think, gets passed along a lot, and I think we can all latch on to the evidence part of it. But in reality, the true definition includes and is crucial to use that evidence in ways that align with the patient's goals. And so as content specialists and in each of our skill sets, it's not enough to know what the data says. It's also important that we have understood what the patient wants so that we can make recommendations that take into account both of those things. And it's impossible to get to a point where a patient is willing to share what their goals are, what they are hoping for in a pregnancy, without having built relationship. And it also is impossible to maintain trust when we don't share, this is what I think is safe, this is what I do not think is safe, and to be willing to have those really hard conversations, because sometimes what we want isn't safe, or getting there is going to be risky. And so I think being able to hold all of that in both hands, and not be so tied to the data that we don't get to understand what our patients want, or to assume that they won't understand the data, or that they can't have a say, is truly detrimental. And so I always ask that, and then I also try really hard to make sure that my patients understand what we're talking about. It's so easy for us in the profession to get used to all the medical terms, and we know what it means, and the abbreviations, But, someone told me once when I was coming through my medical training, what is your everyday is somebody else's once in a lifetime experience. And if we forget that, then we will forget what it feels like to go somewhere new and to have a new experience. And so it's a lot to keep in balance, but it's so necessary.
Yeah, that point is important about, I think all of you kind of brought in meeting our patients or clients or family or whomever where they are in that moment, and understanding that the knowledge that we bring is for consumption and not to use to blame anyone for anything. And so in that vein, we understand that those of us that are hanging around in this space, we continue to seek knowledge for this space, right? But what about our, colleagues and friends and those in the community that need a little more education and a little more support in how they approach clients, patients, or whomever? And so we talked some about implicit bias trainings and all these different trainings, but what trainings have you all found to be helpful, specifically in the healthcare and then in the community setting too? On the provider side, for the providers, yeah.
I honestly feel like the patient stories are the most impactful. When we go to, like I said, our hospital participates in Texas AIM, and so we see the PowerPoint, we see all the numbers, but it's those videos with those patient stories that, to me, really drive a change in, because you can't like watch that and not walk away feeling like you are called to action. So I think that involving the patients in every aspect of like process improvement or quality assurance that any projects, I think having a patient on that board to tell their stories, come back and speak to the nursing staff, to the providers, go out into the community and tell their stories. I think if we can get more patient stories out there, and you have a human that you are connecting with the stats, I think that, to me, that's been the most impactful for sure.
I agree. I think the stories are so important. And sometimes patients won't share them unless we specifically ask them. And I also think it's, insurance companies, not just for pregnancy, but for all healthcare, is increasingly moving towards quality as a metric for how people and providers get reimbursed for the work that we're doing. And so we're beginning to think through, what does it look like for a care team, not necessarily just the provider, but all of the people who are involved in a patient's care, the provider, the lactation specialist, any of our educators, our integrated behavioral health managers. What does it look like to provide an experience that we can then look back and say, we did everything that we could to prevent an outcome, and that our C-section rate is lower, and that fewer of our babies are born low weight. And so, holding people accountable for that data will drive a lot of that education, because you cannot do both, right? You cannot be ignoring bias and still expecting to have good outcomes. And I think that's one of the ways that we're continuing to foster that, as well as getting really good at providing interdisciplinary care.
Lucretia, did you want to add anything? Okay. Well, you all, we've rounded out kind of the questions that I have. The chat has been blowing up, and it is good information. There are some questions there too. And so for our last few minutes, I would like to get to some of the questions that we have in the Q&A box. So let's start there. Okay. Hello, I am an immunization coordinator in the public health sector. The disparities that contribute to the quality of care. Is it safe to say those same individuals lack in being up to date in their vaccines? So it sounds like the question is, do lack of vaccines that are up to date contribute to the disparities that contribute to quality of care? So the question, the disparities that contribute to the quality of care, is it safe to say that those same individuals lack in being up to date in their vaccines? I'll let someone else, one of healthcare providers, answer that, but I would probably say it's not safe for us to assume that. But
I mean, I think it's probably vaccine dependent, right? So one of the vaccines that we give most moms, unless there's a really good reason not to, is Tdap, and that's to prevent pertussis or a pneumonia in the baby. So it's probably dependent upon which vaccine. Certain vaccines are supposed to be given during pregnancy. I always recommend the flu, not just because the flu is miserable, but also because if mom gets sick, baby, might not be doing well either. So I think it's not a blanket statement. And so it depends more on which vaccine we're talking about.
Lauren, did you want to add anything or? Okay. Are we able to educate our younger girls to follow healthy habits that may decrease the mortality and morbidity risk and rate? And Lucretia, I'll start with you, especially since you offer a community perspective.
Yeah, so I actually really like that question. We have built relationships with local schools and teaching about doulas and the importance of doula care and birth and postpartum. We've been very lucky to be able to reach younger ladies. And when I say young, like between 16 and 18 years old, right around that time. And so that has been super helpful, has been like just going out into the community, going to schools, going to high schools, and just giving a presentation on doulas. We've even had several requests for those that are getting ready to graduate to become doulas, which they're understanding the need. And so their whole course of life has been changed just by offering that information. So yeah, absolutely, there is a way.
That's great. Did anyone else want to follow up on that? Okay. Okay. Thank you all so much for the showing and the panel. What kind of challenges have you encountered when educating your clients or patients, specifically Black, around breastfeeding and body feeding? And we'll start with Lauren, since you're in a hospital setting, and I think that may be good for everyone else to answer as well.
Yeah, there's a huge barrier with that because so often they've made up their mind before they get to the hospital that they're not going to breastfeed. So I think we partner with Breastfeeding Success, and I think it's key to that education starts well before they get to the hospital. Sometimes, you're able to really give them facts once they're here, but again, you're kind of dealing with a narrow window of education once in the hospital. So that's the biggest barrier I see. But if we could get them prenatally, like Breastfeeding Success does offer prenatal classes, if that education can start before they enter the hospital, or if once they're in the hospital and you have an amazing nurse there during that golden hour, that if the baby is showing hunger cues, you'd be like, I think you can do it. I think so. We are really encouraging, like having Breastfeeding Success and the lactation consultants work with our nursing staff to implement that. But I think that the key is starting probably educating before arriving to the hospital, because so often we see where they're not willing to change, and that may be from what they've heard from family and friends about breastfeeding. But I just want to get the facts out to them and about the importance and the benefits of breastfeeding.
I agree wholeheartedly. When I take care of moms, we start talking about it around halfway through the pregnancy. So around 18, 20 weeks is when we start talking about it. And I sort of structure the conversation around, well, what are the benefits to you? What are the benefits to the baby? And I preface it with, learning to breastfeed is more like a baby learning to walk. It does not happen overnight. It doesn't happen because you think about it. That would be great. But it's a learned skill, and it's one that often requires coaching and reteaching and coaching and understanding baby and cues. And so I try really hard to connect those patients with our lactation consultant, again, before pregnancy or before delivery, so that they can have some of those initial conversations to sort of understand what that can look like and how great it can be.
Yeah, our birth doulas and postpartum doulas, they have mastered amazing techniques to try to break down those walls of just the fear and the stigma on breastfeeding. And so it starts whenever the mom registers for doula services. And just as a reminder, we only register 30 to 34 weeks. And so I understand what Lauren was saying, like by the time they're already at the hospital, they're going to make their decision. And so this is such a crucial time for the doulas to educate, what is breastfeeding? What does it look like? What are the benefits of it? So we've all came across those barriers. Of really trying to show the importance of breastfeeding, but also not forcing breastfeeding on them because maybe they just don't want to, and that is okay. And so if they do choose to breastfeed, we let them know the benefits of it and teaching them about pumping. That's an alternative. And then also we have specialized support from IBCLC that we can refer them to. And so our postpartum doulas are doing the same thing. They are there with the mamas after the baby is born, offering that breastfeeding support, just latching and positioning and just keeping an eye out for things that are not normal. And if they notice that things are not normal, then they're referring. So just staying within their scope. But there has definitely been some barriers with breastfeeding that once again can go back generations to generations to generations. And we just got to know what our boundaries are and knowing not, when to cross those and just respecting the clients or the patients, their end will, whatever they want.
Yeah, thank you for that. Okay. So I work in a clinic inside of a homeless shelter in Dallas. I've seen a rise in clients that are pregnant, some resources. Do you all have resources that could be shared? And I'm sure AHEC may be able to, if I don't know if this is possible, Megan, but if there are resources, could our panelists email them to you and you email them out to the participants maybe? That seems like a kind of streamlined approach to that.
Yes, I've seen several of you ask in the chat if we can compile all of these resources, so I will definitely do that in our follow-up. Yes, so anybody who has resources too, you can go ahead and email that and I will put it all in a list.
Thank you for that. And then a quick reference list with questions we should be asking our doctors. I know there is there are some questions and the resource is leaving me right now, but Megan, I can send that when I find it. But Lucretia, yeah, you probably know what I'm referencing.
So as for doulas, we use what's called a birth plan. And so I would encourage you to just look at different templates for birth plans. They do have some questions that you can ask, or I think that is super helpful. So I'm just going to say templates for birth plans, because it should technically cover a lot of things. So I would definitely check into that.
Thank you.
And our site uses something called Maternal Passport because it kind of follows you throughout your pregnancy. And if patients don't have that, I just say journal, get a little notebook, and as questions kind of come up, write them down, because you won't remember once you get to the doctor's office, but just try to start writing down all those questions you have. But the Maternal Passport kind of shows what happens at each gestational age throughout the pregnancy, and then you can generate questions that you have from those.
Thank you. And so the next question is about what are some warning signs to look for? It says the work all of you are doing is important. We don't reach every mother. What are some warning signs to look for? What questions should a Black parent ask their OB, and how should they advocate? So to streamline that question, let's try to answer some warning signs and maybe think about probably preeclampsia, and maybe some mental health. Those are the things that we probably see the most. Many of us may see the most. But also for the second piece of that, what question should a Black parent be asking? Megan, I'm going to find that resource and send it, because there are like 10 questions there. And how should they advocate for themselves? I'll also uplift documenting everything, writing questions down prior to going to the provider. So let's kind of focus on that first part of the question for our clinicians.
So I highly recommend the A1 post-birth warning signs. It's a one-pager and it's an acronym, and it covers hypertension and hemorrhage and a lot of the common things that we see patients experience complications from. And I can like share that with you guys if Megan wants to send that out, but it just goes through like signs and symptoms of preeclampsia. If you have a headache, trouble with your vision, if you're having any epigastric pain, if you're vomiting, and then also talks about heavy bleeding and just like changes in like dizziness and things like that could implicate that you're having a lot of blood loss. And it's one page. It actually comes as a refrigerator magnet too, where you can just stick it on your fridge and have those. It's called the post-birth warning signs, but I think it's can apply for during pregnancy as well.
Yeah, I would agree. I think, as a clinician, the first thing that we're always trained to do is to look at the patient. And so as a family member, a partner, that person, what their normal looks like. So when you notice that they're not who you expect them to be, that's when you should really get a doctor or provider involved, because sometimes those symptoms are subtle. And if they've, and sometimes they're just not thinking, oh, that you're right, I have had a headache every day and I've been complaining about it, been too busy to address it. So when you know that your loved one is not looking their normal self, regardless of how small it might seem, and regardless of how much they themselves might not think it's a big deal, it's not going to hurt to call, right? If they call and it's nothing, and you have an appointment and it's nothing, you can all rest assured that you're safe. But if you are wrong and you miss it, that's where it can be really dangerous. So just knowing what normal is for that person and what's not normal for that person, and reaching out as soon as you recognize that.
Thank you. And this will be the last question that we ask live. And if there are others that we weren't able to get to, maybe we can, if you all wanted to maybe email them directly to a panelist or one of us, then we could get to it that way. But you all have been very engaging. So let's get this last question. Why are mom and baby only given a 24-hour time frame and then sent home? I felt when I had my first two sons, being able to get my strength and mental strength within 48 hours was so important compared to the 24 hours. Our bodies are so exhausted from birth.
Well, I'll say I worked at a very large hospital in Dallas-Fort Worth area for like 20 years, and we rarely sent people home at 24 hours. Where I'm working now, it's not uncommon. Like I said, if you have an uncomplicated vaginal delivery and your newborn's GPS negative, 24 hours is kind of the goal. Sometimes the patients want to get out of here. They're like asking when they could get out. It has to do with insurance. Not sure all the background in that, but I would say definitely advocate for yourself. If you're not feeling well at that 24-hour mark, if you feel like you need an additional day in the hospital, like if you feel like your vital signs are off or you're bleeding or you need more time with just newborn education, definitely speak up and mention that to your provider that you would like to remain hospitalized another night.
Yeah, that was something that was driven by insurance many years ago, probably 15 or 20 at this point, that sort of pushed back and aligned, how much was sort of the standard number of days based on what was going on. So if you had a C-section, you got 3 nights. If you had a vaginal delivery, you got, 1 night after delivery. But that assumes that the course afterwards is smooth. So, if there are complications, certainly that can change. They don't necessarily hold to that, but yeah, I think it speaks to the importance of how can we transition people from, families at this point from hospital to home. And so sometimes, even if there's increasingly early visits within the first week of being home. So a mom may go home on one day and then 2 days later be showing up in her provider's office to make sure that transition is going smoothly.
Okay, thank you all. I have just been watching the chat, and it has probably been one of the most interactive chats that I have seen. So thank you all for being so engaged in the discussion. It has been a pleasure for me to be able to moderate this panel with these esteemed panelists with such a wealth of knowledge. And so I appreciate it. Thank you, Megan, and thank you, Texas AHAC, and I'll turn it back over to you all.
Thank you. Thank you so much to each of our panelists. Thank you, Nikutra, for letting us watch Laboring with Hope and stream it here for all of our attendees. I'm really excited for the collaboration to continue in sharing resources. We had people tune in from all over the state, so that'll be really exciting. I do have this presentation recorded, so I will be sharing that in follow-up as well, along with the resources. So probably give me about a week to expect that email just so that I can make sure it's all inclusive. And again, thank you so much. Thank you, Dr. Alex Jones-Adeshna. Thank you, Lauren Montgomery. Thank you, Lucretia Duffy. And thank you, Dr. Nikutra Burse. This was such a great event, and I'm really excited all of you could tune in. And again, if you have any CE questions, please direct them to Chantal Miner.
Thank you. You all have a good day.